Good afternoon, ladies and gentlemen. My name is Angelina Kakooza. I'm a postdoc fellow with Thrive 2. And my postdoctoral research project was on the Zika virus. And I'm going to present to you preliminary findings. The title of my talk is the Zika virus absent from its natural habitat in Uganda? Preliminary findings. This is the outline of my presentation. I'll give you a background of the Zika virus, why I am studying this study, and the objective, how we carried out the methodology, what the preliminary results are and what they mean for Ugandans, and what are the next steps. I'd like to declare that I have nothing to disclose. Now, when we look at arthropod-borne viruses, those are viruses that are transmitted by these insects, arthropods. They have become a major public health concern and an escalating worldwide problem. They are considered to be emerging and re-emerging, and basing on their geographical spread, are increasing the number of susceptible populations that are infected with these viruses. Unfortunately, their actual impact remains unknown. Looking at these maps of the world, looking at the distribution of arboviruses, you see that the countries where seroprevalence studies have been done are very few in Africa. And you can see for Uganda, in the systematic review by Fritzel and colleagues, there's hardly any information about arbovirus seroprevalence. If we look at dengue, one of the arboviruses, you see that the same. You find most of these studies are in the tropical, in Asia and in South America, but hardly any in Uganda. In East Africa, it's mainly from Kenya, where we find many of those studies. And chikungunya, another arbovirus of importance, is primarily conducted in Africa and in Asia, but still Uganda, we are lagging behind. Looking at Zika, which is a topic of interest, we find that in the systematic reviews, we can see countries like Cameroon and Zambia, which have reported seroprevalence studies, and maybe a bit of Brazil, but hardly much in terms of Zika seroprevalence studies. Yesterday, I had the opportunity to have one of our colleagues here, Dr. Masiga, who shared with me a recent paper, came out 2 weeks ago, in a study that has been done in Kenya. And guess what? They have identified Zika virus amongst the population very close to us in the northeastern region near Karamoja. Well, the people who are being surveyed were in Kenya, West Pokot, but they are close to us. Now, coming back to Uganda, the Zika virus was initially isolated in a rhesus monkey in the Zika forest over 70 years ago. And it's spread in humans, and Uganda and other Eastern and African countries moved on as well as to Asia. And the researchers first identified this it was sort of like an accident, because they were looking for yellow fever. It was a surveillance study for yellow fever, but they found out this virus that was in this febrile monkey. This is the structure of the Zika virus. One of the highest resolution definition of any enveloped virus so far. This virus belongs to a group called the Flaviviridae. For many years, this virus was characterized by a mild febrile illness in humans and was of little clinical importance. However, in 2007, it caused an outbreak in several islands in the Yap, Federal States of Micronesia, French Polynesia, with subsequent outbreaks in other Pacific areas. It is transmitted by this mosquito, I beg your pardon, the Aedes aegypti mosquitoes, and scientists believe that it's specifically carried by the Aedes aegypti, which spreads the disease through bites. They usually bite during the day and are incredibly well adapted to thrive alongside humans. They can breed in several places, small pools of water. These are just some examples. If you go back home and you find you have a pan which just has collecting water, be aware that you may be actually allowing these mosquitoes to breed in your compound. Now, how is this virus transmitted? It is transmitted by mother-to-child transmission and also by sexual transmission. There are other modes of transmission which are still under study, like breastfeeding and blood transfusion. Now here we see in this diagram that the Zika virus exists in two transmission cycles. It has the enzootic cycle, which is from mosquito to monkey, and then we have the human-to-human transmission, where the mosquito bites an infected human, who then can transfer it either through mother to child or through the mosquito. The symptoms of this illness are very mild. In fact, they say 80% of people are asymptomatic. Some of us in this room may have actually gotten Zika, but we didn't know. We continued business as usual. The incubation period is about 3 to 12 days, and the common symptoms include things like red eyes, headache, fever, rash, joint pain, and muscle pain. In the pathogenesis, because the majority of people are symptomatic, it may pass undetected. However, there are some who may, especially those who are symptomatic, may go on to have other adverse events, especially if they are pregnant. The mothers, the children may have adverse fetal outcomes. Some have even been reported to die. And in adults, there is a neurological condition called Guillain-Barré syndrome, which has been associated with the Zika virus. To diagnose this virus, we usually use immunoglobulin M, enzyme-linked immunoabsorbent assay. If you find the assay 4 times higher than that in Dengue, you identify that could be Zika. Also, we can use antibody response, and this antibody response usually wanes after the first week. Also, the CDC has recommended to use this reverse transcriptase polymerase chain reaction, primarily on serum as a definite diagnosis, and you can also use nucleic acid testing. Now, serum has been the mode of use, the specimen that has been used to test for Zika. But you can also test for Zika in urine, you can also test for Zika in saliva. And the virus has been reported to spend even longer in urine compared to the rest of the other samples. Now, this epidemic from February the 1st to November 18th, 2016 was spreading with such vengeance because of the birth defects that are being reported, microcephaly in newborns, Guillain-Barré syndrome in adults, that the World Health Organization decided to declare it as a public health emergency of international concern. However, currently, this disease or this virus, infection with this virus, is now considered an enduring public health challenge by the World Health Organization. So the problem is that many of us can be at risk. Basing from what was written in the Lancet Infectious Disease report, more than 2 billion people could be at risk, and in Africa as well. This epidemic is global, posing grave medical, ethical, and economic implications, and has also been associated with potentially devastating birth defects such as microcephaly. Unfortunately, much as we discovered this virus more than 70 years ago, we don't know how big a problem is it in Uganda. Could we be having an ongoing undetected transmission? Could there be another cofactor involved in this infection? This information is very important because it will help us to counsel the pregnant women, raise awareness about this problem, teach us how the children grow and develop when they are in the womb of the mother, and also help the doctors and other health care providers protect the babies of pregnant women. Therefore, our objective was to determine what is the seroprevalence and associated factors for the Zika virus infection among pregnant women in Uganda. How did we go about this? Because the Zika virus was initially isolated in the Zika forest, which is in Entebbe, we decided to actually use our catchment area by looking at all those health units within the area of Lake Victoria. This area around Lake Victoria is forested, woody, and has the water, which is ideal breeding site for these mosquitoes. And Zika, having been initially isolated there, was a very big reason. Secondly, Zika was earlier noted to circulate actively in West and Central Uganda in forest monkeys, which are also very prevalent there. And also Zika has been noted to circulate in an enzoomic transmission cycle between the non-human primates, monkeys, and forest-dwelling mosquitoes. So you can see all this stretch of Lake Victoria, all the health units which were around here were targeted, and there are 16 of them. To begin the study, I started with the low-hanging fruit, where there are the majority of mothers, Entebbe Grade B Hospital. This is one of the 16 selected health units and has a turnover of approximately 677 pregnant women who are seen every month. This is the maternal child health clinic, which is the site at which the study is being conducted. The study population is all pregnant women who were attending this hospital from 14th August 2018 to 14th January 2019, who fulfilled the study criteria. This study was cross-sectional. As soon as the mother arrived at the unit, there was a health education talk about Zika, and I can assure you majority of the mothers had never heard about this animal called Zika. So we told them about it, the risks about it. Those who understood gave us written informed consent. Then we interviewed them about their social demographic characteristics, past medical history, past and present obstetric performances. We only included those who were registered, who are living within that catchment area that I previously explained, who had a history of fever currently or within the last 6 weeks. And those who were 18 years and below, we treated as emancipated minors. We excluded mothers who came in labor, those who had a history suggestive of immune suppressive therapy, and those who were very sick and could not be interviewed. For the lab procedure, we took a sample of urine, 1 ml of urine from each mother, plus 5 ml of whole blood. And these samples were sent to the lab, where we extracted the plasma, and this plasma was then stored in the lab in Entebbe for transport by border with my runner to Uganda Virus Research Institute, which is the laboratory of recommendation here in Uganda. In the Uganda Virus Research Institute, confirmation of all the viral infections was done using RT-PCR. For the dengue and chikungunya, you may be asking yourself why we looked at this. It's because the Aedes aegypti mosquito that I showed you is the same vector that transmits Zika. So we screened this blood for both dengue, chikungunya, and Zika. The Zika IgM test was used as a CDC in-house ELISA. All the antigens, antibodies, and positive controls and conjugates were obtained from the CDC USA. RNA extraction kits were samples of coagen RNA extraction, and the group-specific PCR for the alpha and the flaviviruses. We also used coagen one-step RT-PCR kits. All the primers were obtained from CDC Atlanta, Georgia. This just shows you the flow of the patients. We screened 485 pregnant women. 15 of them, we omitted them. One was in labor, one was not in the catchment area for declined consent. We enrolled 470, but at the end of it, we had to have 468 because 2 did not have complete data. The summary of our results, we were able to have information on 43% of the eligible participants from that site. And the participants were from varied locations as far as Sese Islands. All the participants were negative for IgM ELISA, for Zika, chikungunya, and dengue. But there was one case number 486, whose urine sample was positive. She had an unidentified flavivirus by PCR, but this virus was absent in her serum. Case 486 was a 20-year-old prime gravida, who presented at 24 weeks. She sells watermelon in mobile markets in Entebbe. Her husband is a waiter at a hotel close to the Entebbe Zoo, and he had no symptoms. They had been residing in Nachiwogo, the area close to UVRI, for 9 months prior to the visit at the antenatal. They confirmed that they have many mosquitoes and monkeys in this area, and the only symptom she had when she came to us was fever. And on exam, she was a febrile. The rest of her clinical exam was unremarkable. At the age of approximately 36 weeks, she gave birth to a beautiful baby girl. This was a normal delivery. The baby was weighing 3.5 kilos and has the score of 10. I last saw them last week, 1 month follow-up, and there is baby of 486 with her proud mother. This baby's head circumference is 38.2. She does not have microcephaly. So, what do these results mean? It suggests that there is a 0% prevalence of Zika in this native habitat. It may have disappeared in this habitat, but has been replaced with a new flavivirus. And the absence may be explained by herd immunity, which is a situation in which a sufficient proportion of people are immune to an infectious disease through vaccination or prior illness and make it spread from person to person, unlikely. So, is this virus a threat to Ugandans? Possibly. That it's possible that a large proportion of people have been infected, many without symptoms, and may have had lifelong immunity. Even if herd immunity is behind the reason, we cannot guarantee that an outbreak will not occur when there are people who are exposed and are non-immune. Secondly, the virus can be maintained in the salivatic cycle between the mosquito and the monkey, so we can't be sure. There may be an outbreak, not today, but later in the future. The questions I want to pose to you: could the reason be because of climate change? Could it be because of outdoor spraying? The journey with the Zika virus continues. Much is still unknown. In my next steps, I need to further identify this flavivirus of case 486, follow up the case of case 486 baby. I would like to acknowledge Thrive for having given me this opportunity to study this. Thank you for listening.